So it's 1.4 billion people in the world have hypertension, 130 million American adults. That's nearly half the US adult population. And in the Western world and other places, it's even higher. So 1 in 2 adults over the age of 65 have hypertension. So if you don't have it, someone you know will have it. And what is so interesting about hypertension, and one of the reasons it's kind of so difficult to understand and manage and treat, is that it's silent, right? People understand that it's a silent killer. And that's really kind of true. Is that it starts, there's no symptoms from it. And it starts usually decades before people understand or know that they actually have the disease. And usually they only find out 10, 15, 20 years later.
Hey everyone, welcome back to the Reshape Your Health podcast. I'm your host, Dr. Morgan Nolte, and today we're going to talk a lot about high blood pressure and how technology around monitoring blood pressure is changing. And our guest today is Dr. Jay Shah, and he's an expert cardiologist. He's practiced at Massachusetts General Hospital and the Mayo Clinic, and he's now the Chief Medical Officer for Aktiia. He believes the time has come in medicine for individuals to understand and optimize their own health. I couldn't agree with him more. Dr. Shah, welcome to the podcast. Thanks so much for sharing your time today.
Thank you very much for allowing me to be here, Dr. Nolte. It's a pleasure.
Yeah, so let's get started just with your story. I'm always fascinated in people's stories because my brother is a physician, and I know the sacrifice and the toll that it takes to kind of get to that place in life. So why did you decide to go on that arduous journey to become a cardiologist, and how did that decision kind of lead you to where you are today?
Sure. Yeah, it was a long journey and sort of a winding path for me, at least. I thought about going into medicine fairly early in life. I have a physician in my family, and I think that influenced some of that, as well as, I did really enjoy the sciences and biology and stuff in school. And so I thought that medicine might be the right calling because it allowed me to sort of talk about science, but also interact with people, which I definitely enjoyed doing. But, you make that decision fairly early in life without probably understanding fully really what practicing medicine means. But at any rate, I made those decisions, and I certainly have not regretted them in any significant way. I did my medical school at a city general hospital in Kansas City, University of Missouri, which is, fairly understaffed city hospital, safety net kind of place, which was actually kind of fantastic to be a medical student because they were so understaffed. You got a lot of responsibility. And then my journey took me to Massachusetts General Hospital, where I really it opened my eyes and what you could do in medicine, because, my colleagues were, all sort of either past or future leaders in some significant way. I'd have colleagues that are, running, have come to Mass General from running, NGOs in Africa, or the other ones that have come from McKinsey, and then they were going to, start a biotech afterwards. Sort of really drastically different peer set, which was phenomenal. The other thing that I think about all the time is that I think ended up going there because that's where I met my wife, and which was phenomenal. I did my cardiology training at Washington University in St. Louis, which is a fantastic place to get a deep clinical experience, huge hospital and catchment area. And so I really came out, really heavily, practiced after all that training. And then I ended up starting my own practice from scratch. So learned a lot of the business of starting a practice, running a business, and sort of built that up over 7 years. And then finally got the opportunity to work at Mayo Clinic, which I've done for the last 3.5. And I sort of built up a program for complex aortic diseases within one of their sites. And about 1.5 years, almost 2 years ago now, I got the opportunity to change directions fairly drastically and join Aktiia as chief medical officer. So it's a Swiss startup, as you said, working on the massive problem of hypertension. And so I've, for the last almost 2 years, been the chief medical officer there.
Yeah. So let's kind of start with, you said it's a mass problem of hypertension. And I throw this statistic around a lot that 88% of adults have some degree of insulin resistance or metabolic dysfunction. High blood pressure, of course, can be a symptom of that. Do you have any like statistics on the prevalence of high blood pressure and why this is such a big
Yeah.
problem that often goes unrecognized?
I'll give you the statistics. They're fairly staggering. They're also kind of too big to actually really have a tangible sense of. So it's 1.4 billion people in the world have hypertension, 130 million American adults. That's nearly half the US adult population. And in the Western world and other places, it's even higher. So 1 in 2 adults over the age of 65 have hypertension. So if you don't have it, someone you know will have it. And what is so interesting about hypertension, and one of the reasons it's kind of so difficult to understand and manage and treat, is that it's silent, right? People understand that it's a silent killer, and that's really kind of true. Is that there's no symptoms from it, and it starts usually decades before people understand or know that they actually have the disease, and usually they only find out 10, 15, 20 years later, oftentimes when some event has occurred that has been primarily driven by the underlying problem of hypertension. So it's a really, it is the world's most common chronic disease. And so just kind of like diabetes and insulin resistance, it is so silent, but that's when it does its damage. That's when it starts its real underlying detriment on the body and the organs. And it's not just cardiovascular diseases. Blood pressure affects your brain, your eyes, your kidneys, your aorta, your reproductive organs, your heart, of course. And so it has so many different effects that it is, the WHO estimates that it kills directly about 19 million people a year.
Wow. So when you were working in cardiology, we were speaking offline, you were more of a direct practitioner, a direct cardiologist. Were you frustrated that maybe people were coming in their 50s, 60s, 70s when you know that this has been going on for decades? Did that kind of spur something in you to do something a little bit more preventative?
Yeah, I think that was a part of it. I mean, I had been in practice for over 10 years before I sort of took this right turn in my career. And for 10 years, I mean, I loved what I was doing. I still do enjoy practicing. But like you said, it's oftentimes, almost always, people coming to see me after some event has occurred, right? They have a heart attack, they need a surgery, they need a procedure, they're having some symptoms. These are all manifestations of some underlying chronic disease, largely, most of the time, that has been there for a long period of time. And almost always, we'll get them through the sort of short-term, the surgery, the procedure, the hospitalization, whatever it is they need. And it's great that we have all the technology and expertise to do that. And almost always they'll come back to me in the office and they'll ask me, "Doctor, why did this happen?"
Yeah.
And usually there's no one answer, almost always, but the most common answer that I tell them is that, look, the problems that caused these events started 30 years ago. It had to do with your diet. It had to do with exercise, activity, smoking, high blood pressure, diabetes, obesity, whatever it is. Those are the most common large chronic diseases that lead to these events. That's why this happened. So, it's a sort of a moment of truth, and people, realize oftentimes, well, too late, that those chronic diseases end up causing these problems.
Yeah. So going back, 30 years, 20 years, 10 years even, what are some of those early signs of hypertension that are often missed?
That's the catch. There aren't any. That's the thing, is that's why that it's so difficult. And usually in the 20s, 30s, and 40s of life, people aren't necessarily as attuned to their health. They're not as conscious that, oh, I might have some health problem. It's usually that I'm young, I'm healthy, by all accounts and appearances. Everything looks good. They don't necessarily go to the doctor very often, or if at all. So it's sort of a catch-22. And so the only realistic way that somebody knows that they actually have hypertension is they check their blood pressure. And traditionally that's done with an upper arm cuff that everybody knows has been around for 5 decades, and there are billions of them out there. But a cuff gives you one reading at one moment in time once. And it's very easy to assume that that one reading, one time, is the stable nature of your blood pressure, or that one reading represents what your blood pressure is 24 hours a day, 7 days a week, 30 days a month, 365 days a year. And the truth is that blood pressure, like every other physiologic parameter, is constantly fluctuating.
Yep.
And so to really understand what your blood pressure levels are and are they in an optimal range, you have to take multiple measurements at multiple points in time, kind of continuously and longitudinally, so you can really get a sense of, is this outside the optimal range or is it within an optimal range, to really understand that.
I think of people like my husband, who is about 6'1", 155, maybe, like what? So he's very tall and slender. And every time he goes to the doctor, they're like, your blood pressure's high. And I take it at home and it's perfect. I mean, it's in the 1 teens over 70s. And so I think that's a really good example. He's very active. He's a farmer. He eats healthy, but he has white coat syndrome, where they go to the doctor and it's artificially high. What are some other examples that you can think of from your own practice of people that have, maybe a spot check high blood pressure and potentially could be prescribed blood pressure medications that they didn't need, or maybe a higher doses than what they need?
It's a common problem. And so white coat hypertension, which is maybe in your husband's case, exists almost in 35% of individuals.
Wow.
So that's a huge number.
Yeah.
Some 25 to 35%. Another 15% is what's called masked hypertension, which is the opposite. Their blood pressure is normal in the physician's office. So the physician and they think, well, everything's good. And they don't ever go home and check it because they don't feel anything and they had the normal reading in the office, but it's actually high at home. That's maybe another 10 to 15% of people. And what is probably the most common, though, is the write-off. That's what I call it. So you check the blood pressure, whether it's at home or in the office, but it's one-time reading. And let's say it's sort of like borderline 138/85. It's human nature, honestly, and it's very easy to write that off. Oh, I had stress today, or I had 2 cups of coffee, or I ran here, or somebody yelled at me, or I had a fight with my spouse, or my kids were bothering me, or 7,000 reasons that the blood pressure might be a little high. And so it's easy to write that one data point off. But what about the rest of the time? And, nobody's routinely using a cuff like 4 to 5 times a day or more,
right?
And to kind of really understand those patterns over time. And so that's where the sort of one-off measurement really is difficult in the context of real life. If you look at academic guidelines of how to measure blood pressure, they recommend 4 times a day, every day, for at least a week or 2 to really understand your blood pressure. But the truth is, even people who have hypertension, only a quarter of them actually use their cuff even once a week.
Yes.
So there's a big mismatch between the recommendations and what people are actually willing to do. And cuffs have been around for decades and they're easy to use and they're not expensive. So there's a discordance between what that technology can actually do in the real world. And that's where there's a gap.
I'm also thinking of my experience as a geriatric physical therapist in home care. And so each new patient, we had to do a medication reconciliation and we had to educate them on their blood pressure medications. And for example, you're not supposed to take this medication if your top blood pressure number is under 90, or if your pulse, like how fast your heart is, under 60. Are you checking your blood pressure before you take this medication to prevent an overdose? Or an overshoot, not an overdose. And they're like, oh no, I never checked my blood. Well, that's maybe why you ended up in the hospital. You went in with these symptoms. And so I think a lot of people don't understand the importance of proper medication dosing to their needs. I mean, blood sugar is another huge aspect here that I think we can prevent a lot of hospitalizations. We know medication adverse effects are a huge risk of hospitalizations for older adults. So if they didn't have to manually check it and it was just, on their phone, what's my blood pressure? Do I need to take this medication or not? How many hospitalizations can we prevent? How much money does that save our society in the long run? So I think there's a lot of applications here. and ripple effects too, because that saves their family members stress, that saves the hospital stress, that saves them stress. So let me ask you this. You've got, your company kind of has developed this wearable blood pressure device. Will you just explain what it is and how it works?
Yeah. So just kind of getting back to the theme that you just touched on is really understanding your blood pressure and its consistency over long periods of time is really our perspective and our sort of, as a company, our sort of benchmark of how we really want to look at and understand blood pressure, because that's how blood pressure does its damage. It doesn't actually matter what your blood pressure is 1 minute of the day, 1 hour, even 1 week. Generally, not always, but generally, that's not how we, physiologically, how blood pressure does its damage. Even in the example you gave with the overdosing of medications, it's generally not recommended to dose blood pressure medicines episodically based on one reading. In fact, you probably want to look at, general trends and then come to some agreement of what is the optimal sort of range that this person should be in. As a physician, we can fluctuate, we can, move those ranges based on that person, individualize it to that person. If someone's elderly and frail and at risk of passing out, well, let's liberalize that range so we're not over treating. But for the vast majority, it's actually the opposite problem, where we have an optimal range and they're usually outside that optimal range and we're not treating adequately enough. But either way, it's a problem. So really understanding what is the sort of optimal range over time, and also what is that person's blood pressure pattern over time. And that's really what Aktiia at its core, that is core innovation, has really developed. And it's a combination of a device, which is a very simple, sleek, sort of Swiss design wearable with a pod that sits on your wrist, and software that sits on your phone, as well as in a physician's office, where this, through optical signals, will take blood pressure measurements as well as heart rate and deliver it automatically, passively, and immediately to both your device as well as your physician. And so what it does is, over a day, we get about 25 to 30 readings in a day. You don't feel it. You don't have to sit in a specific position. You don't have to do anything other than just live your life and wear it. And we'll get this trend over a long period of time. And again, not just one day, but over weeks, months, and years, we can really get a very clear understanding and idea of this one individual's blood pressure pattern. And that allows both you and your physician and healthcare providers to really optimize your management, treatment, and everything based on this sort of data.
Yeah, I think it's really cool. There's a lot of things that I want to discuss, like the Hawthorne effect, and
Sure.
how we can use this to really de-prescribe medications for people that are losing weight, getting healthy. But before we get there, I want you to talk about some of the research that's been done, because I know there's skeptics out there and like, well, how does that work?
Sure.
It's not squeezing my wrist. So
Correct. Yeah.
what's some of the research that you guys have done on this product?
Yeah. So all blood pressure products are regulated medical devices. So where we start is in massive and high volume validation studies. And so we've done that extensively, and we have, it's all on our website, everything's published. So we've done validation studies to validate it across a large range of ages, from 21 now up to 85, different skin tones, different hair follicle densities, different weights, different blood pressure ranges. These are all very specified sort of validation cohorts that we have to show regulatory agencies that our device performs adequately and is comparable to any other blood pressure device. And we've done that in the markets we're regulated in. That's how we've gotten regulatory approval. Now, after that type of study, now we're expanding the studies to go beyond sort of this general cohort of people, to diabetics, to chronic kidney disease, to sicker people, to elderly, more elderly, to now looking at other types of applications, like, can we prevent ER hospitalizations from hypertensive crisis? Can we look at stroke post-stroke care and hypertension, and on and on and on. So we're actually now deploying it in a real world clinical practice and seeing how this application that combines a core innovation, a technology innovation, but also an improvement in the overall data workflow of how blood pressure data comes into healthcare systems and how we as physicians and providers can act on that data and really improve overall sort of, care for people with hypertension. Yeah. So that's sort of the world of research that we're doing. We have tens of now close to probably to 100 of different research partners all across the globe. And we are continually expanding our research data set.
And over 3 million data points is what I read online. I'm guessing it's maybe surpassed that even now.
Yeah. So now we're close to 100 million.
Yeah. I was like 3 million might be an outdated number.
Yeah.
Over 100 million data points, I think is really, really cool with all the published research. I do believe this is the direction of medicine, more personalized, continuous monitoring, people really taking ownership of their health and gaining that information to empower them, make the lifestyle changes necessary. They're not just going to depend on their doctor to prescribe a medication to take care of their blood pressure. They're going to see in real time,
right?
Oh my gosh, I just had that to eat, or, oh, I didn't sleep tonight, or, oh, I exercised today and look what that did to my blood pressure. So let's kind of talk about the Hawthorne effect before we get into those lifestyle changes. So my dad and I did too. I really experienced the Hawthorne effect when I was wearing a continuous glucose monitor to try it out. Will you explain to people what that is?
Sure. So the Hawthorne effect is the phenomenon of simply exposing people to their own data causes that person to make changes to improve some underlying cause of that data. So for example, if you were wearing a CGM, a continuous glucose monitor, you would be looking at your blood glucose and then using that data as feedbacks to yourself to say, oh, I ate this thing for breakfast or lunch or dinner, and I saw a significant spike in my glucose with the CGM. Let me modify what I'm eating. Let me modify and it empowers you, like you were saying, to make that change, to give you that knowledge and information so that then you can go and make that change and then see the results of it. Yep. And then say, okay, the next day, the next week, okay, look, I've made that change and look, these patterns are better. So we've actually done a study on that with our device in Europe. And we looked at people who gave us consent to look at their data, of course. And we looked at people who started using Aktiia who were hypertensive in the first week of use and compared it to people who had normal blood pressure in the first week of use. And over the 6-month period, the people who were hypertensive statistically significantly lowered their own blood pressure by about 5 millimeters of mercury as compared to the others. Now, we don't know, this is a real world study, so we don't really know what they did, but the idea of the Hawthorne effect, showing them their own data and allowing them to look at it and say, okay, let me go make some changes here, whether it's talk to their physician or look online or empower themselves with knowledge and make some changes, whether it's lifestyle, sodium, exercise, et cetera. And they were able to lower their blood pressure in a statistically significant way. 5 millimeters of mercury doesn't sound like a lot to most people, but it correlates to about a 10% risk reduction in cardiovascular disease. So it's not trivial at all. And that was an average. So there were plenty of people who had significantly more.
Yeah, and it was only 6 months. So if they continue those lifestyle changes, it's going to continue to go down into a healthy range.
Correct.
I just thought that was really interesting. And for my dad, especially, who's very resistant to education, I think he has some difficulty remembering things that we tell him sometimes.
Sure. Yeah.
They need that instant feedback. And also his physician's assistant had access to the data too. Mm-hmm. So he really felt like he was being watched because, oh man, if I eat that, she's going to see it and she's going to want to increase my meds. And so I think that's a really practical approach. However, I do believe that there are going to be some barriers to implementation with physician buy-in. So have you guys addressed that, or have you experienced that where you're trying to educate people on the benefits of this wearable technology and physicians are like, oh, we don't need that?
I've actually been pretty surprised. So in all our conversations, and I've had now hundreds and hundreds with physician partners at academic centers, clinical centers, practices all over the world, and researchers, I think almost entirely, with very few exceptions, realize that the way we treat, look at, manage, and try to optimize blood pressure is fairly antiquated and it doesn't work very well. So I don't think there's much debate about what we're doing today isn't great overall. Where the resistance comes in is it's a new technology. And this is looking to, honestly replace technology that has been around for over 100 years, that every physician in the world has trained on, and every physician in the world and PA and nurse practitioner and any healthcare provider and nurse has always done their entire career. So to take out or to replace such a cornerstone of a basic tenet of healthcare, which is blood pressure measurement, that's the challenge. That's how do you get people to buy in and trust the data is really the thing. That's why we're so committed to research. That's why we're so committed to being transparent about what we do well, what we need to get better in. And we understand that this is going to be a learning process and this is going to be a continuously improving technology. And we accept that. So that's sort of our approach. But that's really where I think the primary struggle will be. I don't think people really doubt or debate the utility of a better way to look at blood pressure. It's just a matter of gaining the trust.
I'm kind of curious too. So when I tried my CGM, there was definitely a discrepancy, a calibration period between like a finger prick and then what I was getting on my CGM, and mine was from Levels Health. And so I emailed their customer support and I said, hey, what's going on here? And they sent back a really good explanation that the gold standard is a phlebotomy measurement. So you get your blood drawn. After that, the blood prick, and then the interstitial measurement, which is what a CGM does. It doesn't measure your blood, it measures the fluid between your cells. All of those have margins of error.
That's right.
So she said, it's more helpful to look at your trends over time. So how many points is your blood sugar going up after a meal or down after exercise or up after stress or sleep, versus saying this is exactly what my blood sugar is right now in this moment. Is that kind of how it is with this wearable blood pressure device as well? Or is it a little bit more in sync with the gold standard of blood pressure measurement?
Well, so it's very similar to what you just described. Okay. The gold standard of blood pressure measurement is an invasive arterial catheter sitting in the aorta. So not likely or practical for outpatient, home use.
Yeah.
Every single cuff on the market has a significant range of error. And they're not necessarily the gold standard of blood pressure measurement, but they are the standard of how we measure blood pressure at home.
Yep.
But they have a significant measurement error as well. And so our device also has a measurement error as well. Now, as we published and is on our website, our measurement error is very comparable to a cuff's measurement error when in the standard seated, relaxed position with your back against the chair, feet against the floor, in the way that all cuffs have only been validated. And that position and environment is the following, just so people know. Your feet are flat on the floor, your back is against a chair, you're in a quiet room, you have taken 5 minutes, you haven't spoken, you haven't eaten, you haven't drank anything for 30 minutes, you have no coffee, no alcohol, no children, empty bladder, no food, no clothing on your upper arm. And I think those are the main things. So that's the environment that you're supposed to take a blood pressure in, which, honestly, who does that, right? Even in medical offices, we don't do that.
Yeah.
But that's the only validation position. But our device is taking measurements when you're standing, when you're lying down, when you're seated, when your arm is over your head, when you're sleeping, when you're in meetings. It's taking measurements at all different times. And so we have validation on all those different body positions. And our comparison, our benchmark, isn't a standard automated upper arm cuff because that has too much of a range of error. How we've done all our validation studies is as rigorous as we can make it, is that we do the auscultation method of measuring blood pressure with a mercury column. And that's where you put a stethoscope on and the person listens to your artery, but not with one observer, with two simultaneously listening with a bifurcated stethoscope. So it's called double auscultation. And those two observers have to agree on the reference blood pressure within 5 millimeters of mercury. And that's what we take as our reference. And that's what we compare it to. So we designed our trials with as high of rigor as possible for non-invasive measurement of blood pressure. And so that's the standard we hold ourselves to.
Thank you so much for that explanation, because there are so many skeptics out there and there's so much information online. It can be hard to know who to trust. And I do try to bring on credible people onto this podcast. So let me ask you this. Is insurance going to pay for it? And when is it going to be available in the United States?
So the first question is almost certainly no. They don't cover any blood pressure device at home for home use, so it's not likely they'll cover it. And in the markets that we're in already, which we're in 9, it's sold over the counter. That's one way. That's the primary way it's sold to consumers right now. And so I think that will continue. I do think there are some opportunities, because we have a significant software component, that there might be an opportunity in the future to have it classified as software as a medical device, and that opens an avenue for some reimbursement from insurance. But at the beginning, no, I would say it's over the counter. And I think to answer your second question, I think so. We're in 7 countries in Europe, UK, Canada, Australia, New Zealand. We are targeting the US market for about a year and a half, about 18 months. And that has to do with the rigorous burden of regulatory approval that exists in the US. Yeah.
Yep. Okay. And then so if it's over the counter, then they would not need a physician's order to get this wearable technology.
To order it from our website and set it up at home, and
Okay. And then if it's over the counter, is there a way that people can give their doctor access to the data if the doctor didn't necessarily order it? I'm thinking about people, Zivli members who are losing weight, who are on blood pressure medication, who want to reduce it.
Yeah. Or any number of medical scenarios. So the answer is yes. And in our current markets, we've already built sort of a physician portal or interface for data, and where they can see in one place all their patients that are using Aktiia, and we're doing that in Europe already. And eventually it would integrate into their electronic health records, so that your data, and it's automatic. So right now, what you have to do with anything, any sort of devices, you have to push it, email it, send it into a portal. You have to take some active sort of approach. But with our software and program, it actually goes automatic. Once you've linked to a physician's office that's using our software, the data goes automatically. And so you don't have to do anything, they don't have to do anything, and it'll just show up on their in their data portal.
That's really interesting. Okay, cool. So you're trying to make it as easy as possible for people to use it, to share the data. Let's talk about what people normally do when they see this data. So you're a cardiologist, you practiced for many years. What did you tell your patients to do from a lifestyle change standpoint to reduce their blood pressure without medication?
Yeah, I mean, here's the thing, is that almost all people, I mean, even if I just ask, most of my patients, like, what do you think you should do to lower your blood? They'll be able to rattle off 5 of the things that they know that probably are written in the guidelines. Oh, I should probably lose weight. I should probably stop smoking. I should reduce my alcohol consumption, sodium consumption. I should exercise more. And that covers like most of it, and here's the catch, is that from a behavioral science perspective, a rattling off 5 to 7 very difficult lifestyle changes is very, very poorly received, honestly, by most people. And they are not able to sort of actually integrate any of those changes into their day-to-day life. So one of the opportunities, and so that's generally what happens, like the physician or provider will just rattle off, here's 7 things to do, or they'll print out the AHA's guidelines on lifestyle and just give it to the patient. And there's 7 ways to lower your blood pressure. But that doesn't really fit with sort of how behavioral science works. It doesn't really fit with behavioral change and how people actually make real change with things that are so deeply embedded, like diet and exercise and activity, into their daily life and culture. So it's important, I think, and as we build software around our core technology, this is our approach. It's important to give people an understanding about what is important to them, what makes a difference to them, and how does that intervention actually affect their blood pressure, sort of like A/B testing. And so here's a good example. Let's talk about sodium for a minute. So sodium is a common, almost always talked about salt reduction for blood pressure. But here's the thing, only 50% of people are salt sensitive. So for half the people, we spend time and energy and explanations, and they might go and start trying to read labels, and as difficult as it is to actually reduce your sodium intake, for half people, it doesn't matter.
Interesting.
We don't know, though, for which half it matters and for which half it doesn't. And so one of the aspects of having a software that's on a device that's with somebody every single day, and that has far more power, honestly, than a physician over somebody, or at least allows them to interact with on a routine basis, is to do some sort of individual tests. Let's start a sodium reduction program for 1 month. Do one thing. That's it. Sodium reduction only for 1 month. Let's help you read labels. Let's help you understand how sodium reduction is so difficult. Let's help you. And then let's assess that effect after 4 weeks on your overall blood pressure averages. That's what we can not one time reading averages. We want to see a trend. Did it change? And if it didn't change, you're probably not salt sensitive.
Yeah.
And if it did change, okay, we can say, okay, so this component is actually something worthwhile doing. And then keep that going. And now let's try dry January and see if alcohol reduction actually makes a difference to your blood pressure, or maybe it doesn't. And so then we can kind of measure that impact for that individual person of these lifestyle changes that most of the time we just sort of regurgitate to people, and we have no idea whether it makes any difference or not, and neither do they. And which is why most of the time they don't stick with those lifestyle changes, and that's human nature. So if you see the impact, the effect, going back to your comments like your dad or you're on the Hawthorne effect, if you see the effect of those interventions, you'll be much more likely to say, okay, that matters. I should stick with this. It's clearly making a difference. And so that's really the power of utilizing the software to wrap around this core technology, but then wrap around these sort of feedback loops for people.
I think even after the technology is off, so even after my CGM is off, I'm still walking after meals. Right. I'm still watching my portions more. I'm still doing all of those things all of the insights that I gained, I'm continuing to do.
Exactly.
And I think from a learning standpoint, you're really capitalizing on multiple modes. You're getting the visual, you're getting the tactile, you're getting that reflection in action, the reflection on action. So it's so much more effective than just handing someone a paper that's like, here's 7 ways to lower your blood pressure.
Exactly.
Thanks, doc. See you in 6 months.
Yeah.
For another blood pressure check.
Right.
So,
right.
I think that's great. I think a lot of people do know what to do, and I'm totally with you that behavior change aspects that's where the rubber meets the road. If you can't help people really change their behavior long term, right, then it doesn't matter. And so I'm all about that. I think that this is a great device. I'm excited to see it tried out. Is there anything else that you wanted to share today with the audience about the device, the company, blood pressure?
I would just say that, we are super excited, and hopefully we can bring it to the US market as soon as possible. I think that our perspective is just one to remember, is that the importance of blood pressure is really driven by time. And I think that's, if I leave one thing for audience, and if they sort of retain one thing, that's the most important thing, is how out of range is your blood pressure, not over 1 day, not over 1 week, not even 1 month, but over years to decades. And really being able to understand that pattern over a long period of time is really what's crucial for reducing the death and disease from hypertension. And that's really what we are focused on. And I think that's our main perspective.
Can you just elaborate real quick on why that is? Why does time matter so much?
Yeah. So like any chronic disease, high blood pressure, what happens is that your organs, high blood pressure has to do with the pressure in the arteries or the blood as it's flowing through the arteries, and it's higher than it should be. That's basically what high blood pressure is. Your organs are not built to withstand a certain pressure of the blood flowing into it. So if that blood flowing into those small vessels in an organ, let's say the kidney, over time are higher than they should be for long periods of time. Again, 1 day, it doesn't matter. 1 week, probably not. But 1 month, 1 year, 1 decade, over time, that's what slowly does damage to the tiny vessels in the kidney, as an example. And over time, it leads to destruction of those vessels and then death of kidney cells. And then in the end, kidney damage, kidney failure, needing to be on dialysis. And the same thing goes for your heart, for your brain, for your eyes, for every other organ that high blood pressure affects. So again, it's the time that really causes those problems, not just one day's worth of derangement. It's time. And so it's just sort of, there is such a dissonance between episodic point in time measurements and how blood pressure actually does its damage, that's really where we are focused on this core innovation at Aktiia.
Yeah, well, that's awesome. Thank you so much for your time and your expertise today. I really appreciate it. This was a fun conversation. We haven't talked about this yet on the podcast, and I think people will find it really interesting. Where can they check out the website to maybe if you have a wait list for US
for
or
sure.
anything like that?
Yeah, so the website is www.aktiia.com, aktiia.com. And yes, we do have like a mailing list right now for people who are interested. And then also on all social media channels it's at Aktiia Global.
Cool. All right. Thank you so much, Dr. Shah. I appreciate your time today.
Thank you very much for having me.